Welcome to the ISN-KDIGO Webinar on improving CKD quality of care. I'm Dr. Obrador, I'm a nephrologist from Mexico, and I was a work group member of the Controversies Conference on improving CKD quality of care. I'm going to have the pleasure of serving as moderator of this webinar. These are my disclosures. And as a way of introduction, we all know that CKD is a global public health problem that affects over 850 million people globally, is the 10th leading cause of mortality, contributes to 5 to 10 million deaths annually, and an additional 1.2 million deaths due to cardiovascular disease. So preventing CKD and its progression is an urgent problem of growing global importance. Just to put the Controversies Conference in perspective, I would like to remind you that in 2002, the KDIGO guidelines highlighted the importance of identifying and staging CKD based on eGFR. Then another KDIGO Controversies Conference in 2009 and the CKD guideline of 2012 proposed a new CKD classification that included, in addition to eGFR, albuminuria categories and the etiology of CKD, and also defined CKD progression as rapid if the decline of eGFR was more than 5 mL per minute per year. In the decade that followed 2012, new tools to diagnose and determine CKD prognosis have been developed. Emerging concepts such as precision medicine may apply to CKD. There was a development of several drugs, new drugs that can delay or even prevent progression to kidney failure and cardiovascular events. And there was also a need to address other clinical outcomes such as patient symptoms. So the KDIGO Controversies Conference on improving CKD quality of care of 2022 examined best practices to improve precision of CKD diagnosis and prognosis, the management of complications of CKD to enhance the safety of care and maximize patient quality of life. So the objectives of the conference were to identify tools currently available for the diagnosis and treatment of CKD, to determine the barriers to their implementation, and to discuss strategies for improving the quality of CKD care. So to this end, we have two excellent speakers, Dr. Holly Kramer, who was co-chair of the KDIGO Controversies Conference on improving quality of CKD care. She's professor of medicine and public health at Loyola University in Chicago, and Roberto Pecoits, who was work group leader of the conference as well. He's based in Ann Arbor and the Pontificia Universidade Católica do Paraná. So they will speak about diagnosis and prognosis, Dr. Pecoits, and then Dr. Kramer will talk about management and treatment. And at the end, we will have time for questions and answers. You can write your questions in the question and answer feature of Zoom, and we will try to cover as many as we can. So thank you, Dr. Pecoits. You can start your session.
Thanks, Greg, for the introduction. It was indeed a pleasure to be in Berlin in this conference and participate in the great discussions that we had there, which were led by Dr. Kramer and also Dr. Eckhard. I was thrilled also to accept the invitation to participate in this webinar today. And what I will do is actually to kick us off and start with covering some of the objectives of the conference, especially related to the diagnosis and prognosis. I'll review, the current standard of care in this area, but also bring some discussions that we had during the controversies meeting related to unmet needs and some of the innovations in the area. I'll try to also bring you the information that base the perception that at the moment that we are living in CKD care, we do need to really make sure that we are precise enough in the diagnosis, that we optimize the stratification of risk, both from a kidney and also cardiovascular perspective. And also, I'll discuss some of the new methods and new approaches that were discussed that represent perhaps the forefront in this area, mainly related to CKD diagnosis, monitoring, and risk stratification. And then I'll let Dr. Kramer actually go through some of the implementation aspects of the discussions that we had there in Berlin and final recommendations. So I'll use this algorithm to base my presentation today. It goes from the identification of groups at risk all the way into the actual stratification. I use that as a basis for my presentation, starting by what we know today in terms of the groups of patients that represent high risk to having CKD. This is an important thing to monitor a more cost-effective screening of patients with CKD. What you see here in the slide is the understanding of the scope of patient profiles that actually represent patient at risk to having CKD. On the top part, you can see things that are perhaps more relevant for regions of the world that have already went through the initial steps on developing CKD screening programs and also offer access to CKD care. In the bottom, I think we see some things that are also very important and might be more related to the developing world. And in combination, I think all of these population groups, they really represent, from a global perspective, the big challenges that we have today in really trying to reach to those people with those risk factors and try to really optimize screening and risk stratification in those groups. This is important from the current understanding of how the new guidelines for CKD, which are under final steps for publication, which will emphasize the importance that at the moment that you see a patient at high risk, that not only that you screen and confirm the diagnosis of CKD, but also you have a good idea of the specific causes of CKD as part of the screening and risk stratification. So in terms of screening, I think I have some good news and some new approaches to this. The good news is that what was introduced in KDIGO more than 10 years ago, the concept of identifying and stratifying chronic kidney disease is still very valid and very effective. So with a urine test and a blood test, you can actually quantify the kidney function, and you can actually assess kidney damage, which has been an extremely important step towards the dissemination of CKD screening strategies. It's simple, it's highly accessible, most countries, and also the interpretation can be done in a very standardized approach that I think helped a lot the dissemination of screening and risk stratification strategies. This kind of stuff, this needs to be really simple and accessible to be able to be globally implementable. And creatinine still reigns as the biomarker that is used for the estimation of kidney function over the years. And with the introduction of decision-making tools and ways of really transforming the blood test into an effective estimate of kidney function has helped a lot, millions of people around the world to really have their diagnosis done and prepare those patients to strategies to prevent the progression of kidney disease. There are some things that I think have been also a consensus in discussions during that meeting and in clinical practice currently. The first thing is that because of the availability, the standardization, the cost factors, serum creatinine continues to be the initial test. But cystatin C has been increasing an important tool, especially as a confirmatory test in subgroup of patients that require that confirmation. The group of patients who really need confirmation for tests can be identified in this slide here. People with limb amputation, spinal cord injury, neuromuscular disease, severe malnutrition, and also with severe comorbidities like heart failure and cirrhosis tend to have their kidney function estimation through creatinine limited somewhat, and in which cystatin C has proven to be an important additional test. There are also conditions in which a greater accuracy compared to the creatinine-based GFR might be needed. Just a couple examples here. First one, drug doses really requires a narrow therapeutic range, or the toxicity is really serious. You might need a more accurate diagnosis, and then currently the combination of further evaluation with cystatin C might be justified. And also in kidney donation, where really the greater accuracy is really important for patient safety, especially from the donor's perspective. Another thing that I think has been a consensus is the importance of aggregating a urine test to the risk stratification. And again, the introduction of albuminuria as an additional tool to stratify risk has become very popular, has been introduced in many screening programs in many clinical practices across the world. We have options to that. That's also something that I think became apparent over the years, is that the gold standard might be the albumin creatinine ratio, particularly if you use the first morning void, is more precise. It's still simple to collect in terms of the test, and has proven to be much more precise when taken as a spot urine compared to the very troublesome 24 urine collection. The protein creatinine ratio still being utilized in some regions, but it has proven to be less sensitive and harder to standardize. The third point that we discussed in Berlin, I think it's relevant just to mention here, is the fact that if there are really limited resources to do that, there is a role for the good old dipstick proteinuria. You know, it's a least sensitive, but still very powerful risk factor, and it could be introduced as an alternative to UACR, especially in low resource settings. Finally, when you look at this table that you see here on the right part of the slide, you can see something that might be very useful to standardize, especially the result reporting and help in terms of standardize the classification of patients. And that is the fact that you have today formulas that can actually convert each one of the exams that you see in the bullet points here into a single measure of a category. In other words, you can actually transform a dipstick into a category A1, A2, and A3. Same thing for a protein creatinine ratio. I think this is very good and allows us to communicate in a more standardized way, and it has proven to be an important epidemiological tool and a communication tool that has improved our communication with health systems. Now let's move to risk stratification. I mean, we described some of the important points that have evolved over the years and have been introduced in clinical practice. I think risk stratification is really where we are currently still in need to have perhaps more efficient ways of risk stratifying, especially in subgroup of patients, and also something that represents an area of current innovation that I'll review in the coming slides. So this is the way that risk stratification has been traditionally done and recommended by KDIGO for more than 10 years. Still very valid. It's used very broadly currently. And I feel by communicating with colleagues in other areas, non-nephrologists, that this is something that has helped communication across specialties, including in other healthcare professionals and also other specialties that take care of patients, including primary care physicians. I think one thing that has been discussed quite extensively during that controversies meeting, and I think also becoming very popular, is aggregating kidney failure risk equations to the heat map that I just showed in the previous slide. There are some advantages of estimating the risk of reaching the very advanced phase of kidney failure from a patient perspective and also from a management perspective. So basically what kidney failure risk equations do is actually to use the same variables that we use to put patients into the heat map categories. But what it does is actually to express a % chance of reaching kidney failure or even starting dialysis in a time frame, 2 or 5 years, for example, for the KFRE equation. I think it is considered very reliable, especially if you estimate kidney failure in patients with more advanced kidney disease compared to the early stages. But it is a patient-centered tool because it does respond to questions that typically patients ask us. For instance, when do you expect that I'll have to start dialysis, for instance? And then you can say, wow, you know, you have a 20% chance of starting dialysis within the next 2 years. And I think from a patient perspective, that really is a welcome answer. It might help engaging patients in that, you know, in the fight against the progression of kidney disease. Now, moving more to a innovation in this area, we've been discussing about the potential of incorporating new biomarkers for years now. It is not ready for prime time. I think you noticed by, you know, the content of my discussion so far that we're still counting on biomarkers that have been in practice for so many years. But there is an increasing understanding that particularly in an era that we're moving from interventions that are more focused on tackling the general and high-level risk to something that will be tackling residual risk and more specific pathways, that novel biomarkers might really play an important role and might finally become ready to be at prime time. So especially once we move towards the current implementation of therapies like RAS inhibition, SGLT2 inhibitions, MRAs, I do feel that we are going to be moving to a more precision medicine type of approach to tackle residual risk. And in that way, the incorporation of some of the biomarkers into the clinical trials and then in the decision-making might really become something important. It's just a summary that was presented during the meeting in Berlin, and that shows some of the, you know, important new biomarkers that have been included in some of the observational studies and currently have been implemented in some of the intervention trials too. So those are molecules like inflammatory molecules, like markers of fibrosis that have been measured in different cohorts, both in diabetic, non-diabetic pediatrics, and both from a cross-section perspective, but also in terms of longitudinal changes. And starting to display the potential of incorporation of some of these biomarkers that are more consistently related to higher risk of progression. Finally, I want to just go through a few things that we're discussing in terms of other innovations that are not really related to biomarkers, but rather to first, the new application to O-tools. This is something that was an interesting discussion during the meeting. For instance, point of care ultrasound has become really, really popular, especially with the decreasing cost of equipment and the ease of use that ultrasounds have shown to have. And I think this will lead to potential solutions on how to increase awareness, to increase the access to diagnosis, and also the frequency by which you're doing that if these tools are applied more from a point of care perspective. This will help us in the future with improving technology and the precision of the diagnosis and changes in the image using ultrasound to understand the dynamics of kidney function. It would include some applications of point of care ultrasound to make sure that we are providing more safety to patients, including to procedures. And this revolution about point of care tests, including ultrasounds, but others, could be expanded. For instance, the possibility of expanding point of care diagnosis for kidney function, for instance, creatinine and UACR, that could be done at the point of care level, but also in other areas like potassium and anemia. It is important that these innovations are introduced to clinical trials so that we really understand also the impact of interventions on changes in those new tools to measure and to monitor kidney structure and function. There will be challenges for sure in terms of the requirement for standardization, the integration with the way we document this in our health records. And definitely this has the potential really shifting the way we interpret tests in general with the expansion to a new model with the new application of old tools. Imaging was actually a very popular topic during our discussions during the controversies meetings. And out of the ultrasound that might have a bigger application as a point of care in combination with other ways of assessing patients, new imaging techniques, particular MRIs and also CT techniques, they might actually add a lot of value in upcoming studies, observational and also interventional studies. And this will really help beyond just establishing with new imaging techniques to mechanistic questions or responses to therapies. So it is, again, very important here to integrate the imaging to the way we report our assessment of patients, and also integrate the new imaging tools to clinical trials so that we really make the best use of the implementation of those novel techniques. There's also a feeling that we will need to really take advantage of these innovations. We need to get closer to radiology. And with that, I think nephrologists can become, a kidney imaging expert, really complementing what radiologists do. Finally, I wanted to just touch on something that was discussed a lot, and is what is the future of kidney biopsy after all? Kidney biopsy has been really important over the years to really provide a more precise diagnosis of particular kidney disease, especially glomerular diseases. And in this evolution to precision medicine, is that the is this something that might affect the utilization of kidney biopsy as a strategy to improve our precision in the diagnosis? Well, I think kidney biopsy and the pathology aggregated to that will continue to provide molecular insights to pathways and patterns of disease. And I think it'll still be very important to guide some trials, particularly in rare diseases like glomerular diseases. But really, I think the integration of the approach with the biomarker plus the image plus the pathology that is based on kidney biopsy will continue to be essential in the development of more precise imaging and biomarkers. So I really think, and that was the result of our discussions during the meeting, that biopsy use might actually grow in the future until we can really understand the value of biomarkers and image, because the matching of the results from imaging tests and also biomarkers with the actual tissue findings in the pathological analysis is really a step needed to really validate the biomarkers and the imaging that will be applied in the future. So since there is a perspective that we'll continue to use kidney biopsies to evolve in the area of development of biomarkers and imaging, I think we need to really include in our efforts to really make kidney biopsy safer than it was in the past, by making sure that people are trained to do that and new techniques are included to improve patient safety during the procedure. This is my last slide before we transition to the management discussion here, but this is a figure that is included in the paper that kind of summarizes a little bit of the future, the way that some of the experts that were present during the meeting foresee. So there is a feeling that in times of precision medicine, including precision medicine being introduced in chronic kidney disease, all of these important factors that I discussed during the last 15 minutes, like the biomarkers, the current tests, blood and urine tests that we use to diagnose and monitor progression of chronic kidney disease, plus some new things like advances in kidney biopsy analysis and also imaging and genetic testing and molecular analysis will really increase our capability of characterizing or deep phenotyping patients with chronic kidney disease. Integrated with clinical data that we continue to do in a more efficient way, this will provide outputs that would better characterize the CKD population and perhaps allow us to have a different, more precise, more efficient platform to test new therapies. And with that, I'll stop my presentation. I'll just pass to Dr. Kramer to continue the discussion about managing chronic kidney disease to provide the best care. Holly?
Great. Thanks, Roberto. Okay, so I'm going to be talking about, kind of taking out from where Roberto talked about the diagnosis and the classification of kidney disease, is to really kind of move on to how we manage our patients. So I want to start with a poll question. When treating chronic kidney disease, what is the most important aspect to ensure high quality of care? Is it the care team educates the patient about CKD, patient receives appropriate medication supported by clinical trials, patient is involved in decision-making, or multidisciplinary care? So if you can go ahead and put in your answer to this, and we'll just wait a few seconds while everyone's putting in their comments. It's just kind of a way to kind of think about how you view quality of care. So if we're going to show the results here. And so it seems like most people are saying multidisciplinary care. So that's interesting. So first I want to talk about the models of care. This was discussed at the meeting. And if you think about how most of the models are right now, is that patients are diagnosed late. They're referred to nephrologists when they're close to needing dialysis. And then there's really very little implementation of interventions to get patients to stay off dialysis. And then the cost to your healthcare system is huge, right? So the models of care really need to be changed so that we have earlier diagnosis and staging and prognostication so that the patients can get treated earlier. So we need to think about who pays for the care and who provides for the care so that we can create a mechanism for earlier diagnosis. So some of the things that were talked about during the meeting was the fact that we know that we have an aging population, we have an ongoing obesity epidemic, and if we get more patients to be diagnosed earlier, we're going to have bigger numbers of people who have kidney disease. So we need to figure out how should nephrology referral be integrated into regional management plans, especially given the global variation in local capacity. How can we best leverage the expertise of nephrologists for enhancing care? So who should and should not be referred? And what tasks for CKD care can be delegated to the non-nephrologists, right? So that's the biggest question that we face as we move forward in the future. So here's our next poll question. What do you think delays CKD diagnosis? Is it lack of symptoms, clinician knowledge gaps, lack of clinician concern for early CKD stages, or health system issues such as limited time spent per patient visit? What do you think is the most important factor to delay CKD diagnosis? Go ahead and put in your answer. We'll just wait a few seconds for people to put in, and it's just kind of to get what people's perspectives are for what you think is delaying CKD diagnosis. So we'll show the answers here. So it seems like it's pretty split between lack of symptoms, lack of clinician concern for early CKD stages, health system issues, and then even clinician knowledge gaps. So it seems like a lot of people think a lot of different things. So let's move on to our next slide. The other aspects of CKD care have to do with the integration of CKD care in non-nephrology CKD care. And I think about this as being similar to cardiology. So when I see a patient with chronic kidney disease, I'm thinking about their cardiovascular disease risk. And so that concern should be flipped when a cardiologist sees their patient. They should be thinking about CKD progression. They should be thinking about CKD management the same way we are thinking about cardiovascular disease in our patients. And the other aspect has to do with shared decision-making. If we include patients in these decisions, it will help engage them, empower them, and it'll help increase compliance, and you'll get better outcomes if you utilize shared decision-making. So our next poll questions is, do I go backwards? I'm sorry. Our next discussion has to do with multidisciplinary care, and it seems like everyone kind of agrees that this is really important for quality of care. So we should be including nurses for education, pharmacists for managing the adverse reactions between medications. Everyone should see a dietitian or nutritionist. And of course, we have to rely on our primary care clinicians to provide the routine care. So our next poll question is, what is disease modification? Is it a clinical focus on managing patient symptoms, managing the comorbidities that can accompany a disease, a primary focus on the disease process and its progression, or maximizing survival? So this is actually a question and not a perception issue. So we'll see what people put in for their answers here. And it seems like most people are talking about a primary focus on the disease process and its progression, which is correct. So that is what disease modification is, but it's not something that we normally think about in nephrology. So disease modification is when the primary focus is on the disease process, preventing progression, but not on symptoms and complications. So historically, before we had all these medications that can delay kidney failure or even prevent kidney failure, we really focused on the complications of the disease and maybe even the symptoms. So disease modification is a concept that was established for like rheumatologic diseases, but the participants at the conference really agreed that the interventions that have a positive effect on the kidney disease trajectory and can reduce kidney failure should be defined as a CKD modifier. So that includes ACE and ARBs, sodium glucose cotransporter 2 inhibitors, non-steroidal mineralocorticoid receptor antagonist, and even glucagon-like peptide-1 receptor agonist. You know, of course, 2 days ago, the FLOW trial was stopped early because it showed a 24% relative risk reduction for a 50% decline in GFR and kidney failure. So we know we need to include those medications now on our list of disease modifiers. So, now we have things that we can use. But the problem is, if you look at individuals across the globe, including in high-income countries, the majority of patients are not receiving these disease modifier medications. So this is a study that was from India that looked at patients with kidney disease, showing that about only half of the patients were receiving ACE or ARB. This study is from the United Kingdom, basically showing here what medications would be indicated in their patients with diabetes. So you can see the middle bar are about 170,000 patients with type 2 diabetes and kidney disease. In 2/3 of those patients, SGLT2 inhibitors was indicated, as noted by the orange bar here. And if you look at on the far left, that's the overall CKD cohort. It's almost 1/3 of those patients where SGLT2 inhibitors were indicated. But yet, if you look at where they're prescribed, which is in the green, you can see that in the group with type 2 diabetes, it's only about 20%. And in that group with CKD who does not have diabetes, it's like very, very small number of people are receiving SGLT2 inhibitors. So we have a long way to go to get these patients who would benefit from SGLT2 inhibitors to get these medications. So what are the factors that are inhibiting our patients from getting these types of medications? Just want to show you that, we're here in the provider level, and that we have, of course, patient factors that we may not have much control over. But notice that the biggest part of this whole issue of whether or not a person can access these disease-modifying medications is outside of our own control. It has to do with the organization and the national health policy. So it may be that one of the biggest things that we can do to help our patients to get these medications is to be an advocate for these patients and educate our health system on the importance of these medications. But change is going to eventually occur. The cost of these medications are going to go down, and eventually we're going to have access to these medications. So we need to start thinking now about how we are going to individualize the care of these patients, because we're going to have multiple disease-modifying medications. And that's not a really big issue for nephrologists. Nephrologists practice a lot of individualized care. So we're used to that. So examples would be the fact that we are adjusting medications for the GFR or for dialysis clearance. We're initiating drugs for certain levels of hemoglobin. We're individualizing targets for PTH, calcium, phosphorus. We're changing medications when a patient transitions maybe to dialysis or to a transplant. We're deep prescribing medications at the advanced stages of life. So we're used to individualizing medications. So here's a poll question. Would you combine drugs for CKD if the individual drugs have shown benefit, but not in combination with other drugs? In other words, we have clinical trials of an individual drug, but we don't have trials of the combination of drugs. But would you combine the medications? Yes, no, or maybe? And so we kind of have a split. So about half are saying yes, and about 1/3 of you are saying no. So interesting. So the current practice, of course, is to test a single drug and then rotate to a different drug if it's not effective. That's often what I will do in my patients with type 2 diabetes. But if you look at what the American Heart Association or international groups are saying about the management of heart failure, in the past, they would do sequential therapy where you would start with one drug and then later maybe add a second drug, third drug, fourth drug, a sequential way of adding drugs. What they're now saying is actually that you should have the 4 pillars of heart failure therapy, and that those pillars should all be initiated within a 4-week period, right? So the way of managing heart failure is different. And should we be thinking about something similar in these patients with kidney disease? So here's a poll question. If resources are limited, what patient population would you utilize combination medication therapy? Would it be younger patients, CKD stage 4, severely increased urine albumin excretion, or none? I wouldn't do any of these patients. So let's see what the group here thinks about. So here we're seeing about 1/3 are saying younger patients, and another, maybe about 37% are saying severely increased urine albumin excretion. So let me tell you what was discussed at the consensus conference. So this was a slide that was presented at the conference, just kind of showing you how there's a huge range of risk among people who are in the SGLT2 inhibitor trials. So on the x-axis here is the 5-year risk for having like a 40% decline in GFR or kidney failure, okay? So you can see that the majority of people are actually at a low risk. and you have a small percentage of people who are at high risk of progression, right? And these are people who have type 2 diabetes. So if we look at this is data from meta-analysis of all of the SGLT2 inhibitor clinical trials, and looking at the risk difference, the absolute risk difference for kidney disease progression. So here you can see that if you look at the GFR categories of less than 45, 45 to 60, and greater than 60, the biggest risk difference between getting the drug versus placebo is in the group that has GFR less than 45. But then if we look at the urine albumin to creatinine ratio group, so here's greater than 300, 30 to 300, and less than 30, the risk difference is 18 cases so you're going to reduce 18 cases per 1,000 patients treated versus only about 2 in the groups that have UACR less than 300. So you have the biggest bang for your buck is going to be in this group that has high urine albumin to creatinine ratios. Now also look at the group that had established heart failure at randomization. They also had very large absolute risk differences of around almost 9 cases prevented per 1,000 patient treated versus placebo. Now here is looking at heart failure. And here we have on the top is the urine albumin to creatinine ratio less than 30. So the further you get out to the left, the higher the absolute risk difference with using SGLT2 inhibitors versus placebo. So you can see here that you have a much higher absolute risk difference and more benefit in the group that has the urine albumin to creatinine ratio greater than 300 versus the group that had the urine albumin to creatinine ratio of 30 to 300 or less than 30. And the same thing you see with cardiovascular disease events. So again, you have the highest absolute risk difference or biggest benefit is in this group that had the high urine albumin to creatinine ratios above 300. In the finerenone trials, you saw something similar where here is looking at a glomerular filtration rate, 40% decline or kidney failure. And again, you have larger benefits in the group that has the urine albumin to creatinine ratio greater than 300. Remember, you had to have a urine albumin creatinine ratio at least of 30 milligrams per gram to be entered in the trials of finerenone. Then you also see similar if you have a 57% decline in GFR, which is about a doubling of serum creatinine. And the cardiovascular disease outcome was pretty similar between the two groups. Now, this was not statistically significant for the difference between these two groups, but if I just look at these two bars, to me, these look different. Now, if we talked about the 4 pillars of heart failure, we can also talk about the 4 pillars of treating chronic kidney disease in the setting of diabetes. So the pillars would be using RAS blockade, SGLT2 inhibitors, using the mineralocorticoid receptor antagonists, and then also you now have the GLP-1 receptor agonists. So we can be focusing on the hemodynamic aspects, the inflammation aspects of kidney disease progression, and then also the metabolic dysregulation aspects. So we have the 4 pillars that we can think of in kidney disease, just like how we have the 4 pillars in heart failure. So the consensus of the work group is if the drugs have different mechanism of action, then go ahead and combine them. If the residual risk remains high, you should also combine them. And that would be, for example, if the risk of CKD progression over 5 years exceeds 5%, focus on those who have high urine albumin to creatinine ratios and in patients with heart failure. Now, of course, polypharmacy is going to be an issue in the fact that we're increasing the medications. And I think this goes back to that multidisciplinary care that the audience really emphasized and getting pharmacists involved in the care. So the second to last question is, do you routinely assess patient symptoms when treating chronic kidney disease? Yes or no? Let's ask Roberto. Roberto, do you assess symptoms?
Yeah, no, absolutely. I do feel that this is important, and it became part of my own practice, especially, after some of the recent initiatives that have identified the patient priorities and what patients really care in terms of, things that we can focus on trying to change.
Okay, so it looks like our audience says yes. So it looks like that's great. So one of the things is at this conference is that we did have patients at this meeting, and the patients were really adamant that symptoms be assessed and that nephrologists should be asking us about the symptoms. And so this is just showing you the symptoms, how it changes over time as CKD progresses. And of course, kidney failure is when you have the most symptoms associated with the disease. But really, even with earlier stages, you could have issues like depression, or you might have sleep disorders, and those could be related to comorbidities that are related to the chronic kidney disease. But the most frequent symptoms that the patients really related was that there's pain. Fatigue is a huge disorder, and cognitive disruptions because of the fatigue, and sleep disruptions, and skin problems, and itching, and things like that. And so they would like for us to ask them about us and maybe to just try to determine how we can help them. And asking patients about those symptoms can help them improve the quality of life. So there are a variety of instruments that are available. And we know that evidence from other chronic diseases suggests that regular use of patient-reported outcome measures, which is called PROM, can help focus patients on what really matters and help also focus the care to what matters to the patient. One of the questions from the audience was about the role of apps in CKD management. I thought that was a really great question because the apps can help patients recognize symptoms. So you can use apps to monitor symptoms. It can also be used for the biometric monitoring and help engage the patient. So I thought that was a really great question. So the future of CKD treatment is early diagnosis, informed diagnosis biomarkers, like Roberto had educated us about, the multidisciplinary care that the audience really emphasized, the care that's integrated into the whole health of the patient, and individualized treatments with drug combinations in patients who are high risk. And we need a team approach that addresses patient concerns, values, preferences, and education to empower the patient and the family. So my last question I'm going to end here is, what changes could you make to your existing practice to increase the quality of care for CKD? Incorporate more patient education, systematically assess patient symptoms, utilize combination medication to slow CKD progression in high-risk patients, or all of the above. So let's see what our audience says. And then I'm going to bring this back to the chair. So we got almost everyone saying all of the above. Okay, so I'm going to stop sharing and give this back to Dr. Obrador.
Thank you very much. These were excellent presentations that really summarize all the discussions, very interesting discussions that took place during the conference. I'm going to just ask a couple of questions to Dr. Kramer and Dr. Pecoits that were sent before the beginning of the conference today. One is about CKD screening in low and middle income countries. Any comments about, how to optimize it, given the costs and then the need to have treatments available so that the screening is useful? That's the first question. And the second question is about any applications of artificial intelligence in CKD care.
I can take the first question if you don't mind, Holly. I mentioned
yeah,
something
sure.
that...
Let me just share my screen again and just go down here because I saw that people were going to ask about this. I want to point out to a really nice article that was published by Adir Levin, Vivek Jha, about this whole issue of the early detection. And I think the issue is that you have to get stakeholders, key partners, organizations to work with you. So first you want to know the data on what the kidney failure is, because that's important to health systems because it's extremely costly. If you don't have access to dialysis, obviously that's catastrophic for the patient and the families. So having that data, that's your armor, and you need to develop partnerships. Another thing you can do is to utilize data from your local labs. So if you have a local lab that you can get data from, that they can actually look at the creatinine values, the GFR values, if they do calculate that, and try to look at, if you do find very low values, who are those people? What's the age group, or where are they coming from? And that kind of helped you to identify high-risk groups. You also need to determine your health funding, and what is the value of care to health systems. But I think most health systems understand that the kidney failure is a huge risk for cost and for the patient. So if you have that data, that's really important. And then you can use risk prediction models to kind of emphasize, here's the percentage of people that we have who are at risk for progression and for kidney failure if you have earlier stages. And again, really want to identify and determine stakeholders, what community groups would want to work with you. So it's teach, advocate. I think a really big issue is to advocate for these people and go to your health systems. So again, this is a really great article to look at that would probably give a little bit more details on that particular question.
I just wanted to add, perhaps more from a practical perspective, just to emphasize something that I mentioned during my presentation. I did mention, like new biomarkers and even aggregating another eGFR approach using cystatin C in particular patients. But I really think if you move to a low resource setting, the good old creatinine for estimation of GFR, and then a urine assessment that could be done if there are limitation resources, could be done with a simple dipstick, might be very powerful, especially if you're introducing CKD screening in your setting. So don't think that just because this is a simple tool that this doesn't really add value. And I think with that information, it could really enter in this discussion process that Holly described, really having that simple information, which is not expensive to gather, is a first step, and allows you to really raise the awareness to the high prevalence of CKD, especially if you do that in high risk populations.
I would like to add as well that, for example, in Mexico, which is a middle-income country, we have done a good number of CKD screening programs in different states of the country, and we have developed, or we're in the process of developing, an equation that predicts which patients are going to be screened positive. And because we have seen that about 80% of type 2 diabetic patients turn out to have CKD in our population. So I would encourage to do some research and perhaps to get some good equations that can predict. And in that case, if your availability of you measuring UACR, if it is available, and serum creatinine is not that great, then that can identify patients who are more likely to screen positive.
It's interesting, Greg, what you mentioned, because that might start addressing the second part of a question, which is how AI could help, CKD care in the future. I mean, it is really about gathering information that together identify, effectively patients that might develop CKD. And also, I think technology could help facilitating that identification. I know that there are, in many different countries, some tools introduced to electronic health records that would flag patients at high risk that should be screened, that should be confirmed, even look at a particular altered test and really, highlight that patient actually needs special care, and facilitate the process of referring the patient to the right people to continue with the screening and the risk stratification. So I think this is the beginning of AI or just use of technology that transforms information that is captured in different, from different sources into something that could really help us to really make sure that we can identify all patients at high risk and put them in the right quality care for CKD.
Thank you, Roberto. That's a great question. There is a question about about combination therapy, Dr. Holly. Could you expand a little bit more about the combination between the different agents? You said that they can be combined, that they have different mechanisms of action in high-risk patients. Could you explain a little more about the risks of combining? For example, there was a question about inhibitors of the RAS system with SGLT2 inhibitors. There can be an increased risk of AKI if there are no dose reductions, for example, of diuretics that the patient may also be taking.
So the consensus of that was that in these high-risk patients, so this is these are patients that have urine albumin to creatinine ratios of above 300. And we're talking in the setting of diabetes because most of these medications are only indicated for diabetes, but that may change over time. But right now I'm saying in a patient with, let's say, type 2 diabetes, high urine albumin to creatinine ratios, so above 300 milligrams per gram, and you start, let's say they're already on an ACE or an ARB, they have urine albumin to creatinine ratios of like 500 or 1,000, you would start an SGLT2 inhibitor. And, some people would say if you don't see a 30% decline in the urine albumin to creatinine ratio, then you should start a second agent. And that could be like the non-steroidal mineralocorticoid receptor antagonist, or it could even be, semaglutide. It could be a GLP-1 agonist. But the way I look at it is if they're still in that high risk, they're still above 300 in that far right panel of our heat map, then I think about adding more medications to try to get that urine albumin to creatinine ratios as low as possible. So I'm going to do that with trying to get their blood pressure very well controlled. I use ACE and ARB. I have them on an SGLT2 inhibitor. And then I will add, I frequently do add the non-steroidal mineralocorticoid receptor antagonist. But a lot of my patients are already on the GLP-1 agonist. But I have now actually been pushing some of the primary care physicians to start that medication when I see a person with diabetes and obesity and kidney disease and are not on that. So I'm changing. I'm evolving in how I treat high risk kidney disease, and I am doing more combination medications, despite the fact that we don't have clinical trials. And the consensus of the group was that these drugs have different mechanisms of action, and it makes sense to combine them in patients who are at high risk. So I don't know, Roberto, what do you do?
Yeah, no, and first of all, this is very aligned with the pillar approach in heart failure that you mentioned in your presentation, and it makes total sense. I think we're just changing the way we think about it from, the historic availability of a single drug or class that is effective and safe to use in those patients to multiple options. And I think we are going, including myself, going in the direction of really making sure that the patients cover the mechanistic pathways of the disease, very similar to the heart failure pillar approach that you presented. What I think is also fascinating is that another information that you brought up, and that is to establish as a strategy, as a clinical strategy, to have a time frame in which you really optimize the different medications. I think this is new, and I think a good example for us to think about. And I'm tending to go in that direction, to decreasing the time until I really feel that the patient is covered. Albuminuria, as you mentioned, is a nice short-term thermometer for how strategies are working, and I think this will help a lot. just emphasizing two things more on the safety side, as you mentioned, Greg. I think that two things as we move to a more aggressive approach to implementation of pillars of therapy. One is the fluctuations in kidney function that you see, or kidney biomarkers of kidney function, that increase in creatinine that you see for some of those classes that you mentioned. And this is consistent to all three pillars that we have currently: RASi, SGLT2 inhibitor, and also NS-MRAs. They all cause a slight increase in GFR right after you use it. So I think you need to really keep an eye on that, just to make sure that the patient is not responding with an excessive drop in GFR. And especially, that the GFR is stabilizing after all. I think there is a good feeling that this is actually safe, even if there is a drop of 30–40% of GFR after initiation, that you can continue with that as long as it stabilizes after that. And the second thing that is true for two of the three pillars, MRAs and also RAS inhibition with ACEs and ARBs, and that is the increase in potassium levels that you see. And some patients might react with an increase that puts them into risk. So really measuring before, making sure that you don't start on patients who are hyperkalemic to start. And I think you can use, like 5 as a threshold. Don't start ACEs, ARBs, or MRAs if the potassium level is higher than 5. And actually monitor that after 4 weeks so you can actually see, how the response is. If it's still below 5, that's fine. Perhaps you can even, keep medications if it rises a little bit, and just making sure that if you stop for a short time, and then think about reintroducing, once you stabilize and you find, ways of mitigating that risk.
Yeah. Yeah. I always get a labs 4 weeks after starting any med.
Yeah.
Always.
Yeah. Well, thank you very much. I'm sure there are many other very interesting questions, but we don't have more time. Thank you very much to Roberto and Holly for excellent presentations and discussion, and to the audience for being with us at this ISN-KDIGO webinar. Thank you very much, and thanks to the speakers as well.
Thanks everybody.